Thank you for the kind introduction there. So I'll be talking about improved infusion. This is focusing on a new infusion device we're developing here at Genentech. So just to go over some of the topics of discussion today, or an outline of the presentation, I'll introduce you to the problem we're trying to solve, give a little bit of context around drug transfer and infusion, provide a brief introduction to the device itself, talk a little bit about how it works, the benefits and potential watchouts of such a device, talk a little bit about what makes a drug a good candidate for this device, go back to that problem statement, revisit it in the context of using this device, and then finally I'll wrap up with just a brief look at our vision for the future of this device and what it could be, the potential that it has. So infusion is a cumbersome treatment. In general, it's relatively time consuming. There are other challenges as well, which I've kind of highlighted in blue there, such as dosing errors. CSTDs are costly and not always compatible with our drug product vials. There's also, a pretty significant amount of waste that comes from all the consumables, such as saline bags, syringes, and multiple IV sets required. So using oncology as an example, patients arrive at the clinics, and because their medications are so expensive, generally they're not prepared until the patient actually arrives on site and their diagnostics are clear. The pharmacies generally do the dilution of the drug product from the vial into the saline bag due to contamination issues, but these pharmacies may actually get backed up, which can take additional time to prepare the drug. Once the drug has been diluted into the saline bag, it's then transferred to the nursing ward where it's set up by the nursing staff. The diluted drug product is typically administered over something like 30 minutes or longer. And then finally, to ensure all of the drug product is delivered, the IV line is flushed out with saline over the course of another 10 to 15 minutes. So with this, it's easy to see why subcutaneous injections are so much more convenient and easy to perform, but not every molecule is a good candidate for subcutaneous delivery. Furthermore, if a drug has been formulated for infusion, reformulating for subcutaneous delivery, and developing a device, conducting an additional clinical evaluation is not always a simple or inexpensive proposition. So before I jump into the device, I wanted to provide a little bit of background or context on the use of CSTDs and talk a little bit about drug transfer. Generally, drug is transferred in one of two ways, either with a syringe and a needle. This is sort of the traditional method. The other method is with a closed system transfer device, or CSTD. Generally there are 3 or so devices used in transferring the drug product from the vial into the syringe, and then from the syringe into the saline bag. So you can see on those 2 images there. The primary benefit of using a closed system transfer device is that it prohibits the transfer of contaminants into the system and also prohibits the escape of hazardous drug or vapor concentrations outside the system. So there's an advantage that comes from that, and that there's a reason that those devices are used, even though they're more expensive and they might have compatibility issues with our drugs and drug vials. Also, a little bit of background around how infusions are performed. An IV line is inserted into a vein. The IV set is inserted into a saline bag or vial and primed with saline to remove the air. Then a bag with the diluted drug product, and as we mentioned earlier, that has been transferred generally by the pharmacy. That's connected to the IV set with a secondary line. This is then typically delivered with an IV pump. And then after the drug is finished infusing, saline is used to flush the remaining drug that is left over in the IV set. There are some variations of these steps, but at least step 2, 3, and 4 are generally the same. The IV set is primed, the drug product is delivered, and then finally the drug is flushed out of the IV line. The remaining drug is flushed out of the IV line. So a brief introduction to our new device. So this device is inserted directly into the saline bag. So similar to the closed system transfer device you saw on a couple slides prior, it is configured that same way in between the saline bag and IV set. So the IV set is inserted into the bottom of the device. The drug vial is also attached to the device, and the flow control knob controls flow between saline and drug. So this allows administration directly from the vial itself. So there is no need for the pharmacy to do any transfer of drug from the vial into a separate saline bag. Furthermore, there is no change to the drug or the primary container. So the users may use their standard practice if they prefer. There is nothing that requires them to use this device if they choose to. This device is also a closed system, so it has those same advantages of a CSTD, prevents environmental contaminants from entering the system, and likewise exposure of the HCPs to any drugs. And this is something that we have developed here internally at Genentech and are continuing to develop. So just to show a few cross sections, and I've actually got a video as well to show a little bit more in more detail how it works. But the saline flows through the device into the IV set as a priming step. So the flow control knob shows the direction of flow directly through the device from the saline bag into the IV set. The knob is rotated 90 degrees. This allows drug to flow from the vial into the IV set directly. And then the flushing step, the knob is rotated back to the original position, which allows saline to flow through the device into the IV set. So the drug is here represented by the green. So you can see how the saline pushes the drug in the IV set down through into the patient. So here's a video on how the device works. As this is a prototype, we don't have any packaging, but just to show, this would normally be removed from the packaging, and these would all use aseptic techniques. The device is attached to the vial itself, so it's snapped on into place. The next step is the device the IV set is inserted into the bottom of the device. So this is a spike port, as you would typically see on an IV set. The IV set spike is inserted directly into the bottom, like so. The next step is to take the saline bag, hang it up on the IV pole, and the device is inserted directly into, well, first the cap is removed, the device is inserted directly into the saline bag. Now, steps 2 through 4 can be done in any order. These orders have not been optimized yet, but it also, there is no misuse that can come from using or doing those orders in a different sequence. The next step is that the drip chamber is primed. So this is done by squeezing the drip chamber. And the roller clamp is opened. What this does is removes all of the air from the line. The saline flows into the line and displaces the air. So this is a very standard practice for administering an infusion. The next step, drug delivery or DP delivery. You rotate the knob to the 90 degrees to show flow is coming directly from the vial itself. Generally, you would program an infusion pump with a set flow rate and a set volume. So in this example, this might be a 20 ml vial. You would program the pump to 20 ml. It would pull only 20 ml from the vial. So typically these vials are a little bit overfilled, to ensure that all of the medication can be removed. That is the same with this device. It removes all of that, the volume that the pump requires. Once the pump shuts off, the user will turn the knob back to the original position. This allows saline to flow through the device, and so the remaining drug product that is left in the IV line is then flushed out. This is a brief graph showing the concentration kinetics for a 20 ml drug at 60 mg per mil with this new infusion device. On the y-axis, you have concentration, and on the x-axis, you have volume infused. Now, it's important to note that the first 20 ml of volume infused is going to be saline. That is what has been used to prime the line, so it needs to be flushed out over the first 20 ml. The graph shown in blue shows the standard practice where diluted drug is delivered over a much greater volume at a lower concentration. And then the more brightly colored lines show different flow rate profiles where delivery can occur with less volume than the standard practice and therefore less time. Now, if safety becomes a concern, the flow rate can also be adjusted and reduced to without any impact on that profile as well. So to tee up this slide a bit, we have conducted a formative human factor study and preference study, talking to nurses, pharmacy technicians, pharmacists, and clinic administrators as well, to understand the benefits or challenges of this device as well. So really what came out in terms of the benefits was time for the patients, less time waiting for a chair to open up or waiting for the pharmacy to prepare the drug, less time spent in the chair actually administer or receiving their treatment. For nurses, less time managing each patient is a benefit. And then also, from a pharmacy and pharmacist perspective, if they have to do the preparation, it is easier on them. There's less parts and less things to deal with. It also can ease the pharmacy workload as well, and reduce some of the burden that they go through. And then as far as the practice, it really focuses around removing some of the bottlenecks around freeing up chairs for other patients and easing some of the pharmacy workload, as well as cost savings that come in the form of eliminating the need for CSTDs and some of these other consumables as well. And there's some testimonials down there below. The key outcome of this was 90% of the respondents that we spoke to, would use this device over their current practice. And at Roche, we developed this device in alignment with our business priorities. We are looking for medical advances at a reduced cost to society, and with the elimination of CSTDs, we believe this comes at a reduced cost to society. We also think by reducing some of the burden around preparation and administration time, this improves access, and I'll cover this in a little bit more detail in the coming slide where we look to the future or the vision of this device as well. And then the reduced environmental impact as well by eliminating the need for closed system transfer devices, the additional syringe to withdraw, the secondary line, and the DP saline bag as well. Now, this isn't to say the device is not without its concerns or challenges as well. As we talked to HCPs, one of the primary concerns they had was administering drug product undiluted. And so when we informed them, clinical studies would be planned, and depending on what drug, this assuaged a lot of the concern that they had in making sure that it was safe to use. They also noted that, in some centers, this was just a couple respondents, these shorter infusion times might not be reimbursed the same way longer infusion times are. And so the interesting thing in talking with them was we learned that the increased practice efficiency and consumable cost savings might offset some of the, most of the cost difference that might be there. Furthermore, there was concerns around glass breakage and leakage, or the device breaking. This is really based on the fact that these centers treat oncology drugs, whether or not they are hazardous, they might treat everything as hazardous. And so it highlighted the need to make sure the devices are robust, and minimize breakage as well. And this is maybe the most difficult challenge to overcome, is this device is a change to the standard practice. So there's concern around potentially using the stopcock incorrectly, or HCP or nurses might not know how to use the stopcock correctly. We do think this is a low risk based on the assessment we've performed. And furthermore, we're looking at other design features and working with our human factors team to try to prevent any misuse that might come from using that stopcock incorrectly. As far as training barriers go, this might require new SOPs and training at hospitals and clinics. We don't underestimate the burden that is. And so one of the things that we're looking to do to try to mitigate that is partnering with hospitals and providing them SOP templates and trainings to minimize the impact of this being a change to their standard practice. And then, as with many devices, we have a packaging conundrum. If the device is not co-packed with the device or with the drug, it might not be used. It might be difficult to locate, or it might get lost. Whereas if it's co-packed with the device, it would take up additional storage, cold storage room, which is not ideal. So, depending on the drug needs, those are certain, the packaging option would need to be optimized. So to talk a little bit more about what makes a drug a good candidate, we've talked about this already, but safety is obviously, something on the forefront of this discussion. Infusion-related reactions obviously must be lower limited, as well as Cmax or concentration max driven toxicities also must be lower limited. Furthermore, we also think that antibody drug conjugates are also excluded due to the risk of toxicity. Now, this infusion rate goes hand in hand here, right? If the infusion rate can be adjusted to potentially improve any concerns around safety and how quickly concentrated drug is administered, but that reduces the time benefit of the device. So that's a trade-off that needs to be made around administered flow rate, the time benefit has, and the safety it has as well. For vial size, this device right now is designed for a 5 to 25 ml vial. This is primarily what is in our network. However, we do recognize that different vial sizes and multiple vials, could be accommodated with a change to the device itself relatively simply. And then finally, stability. We want the drug to be stable in solution. It's just not to say that reconstitution is not possible with a different configuration of the device, but this isn't something that we're targeting at the moment. It's not a priority for us, and because we don't have anything within our network that requires it. So going back to the original problem statement, and we think this device potentially addresses many of the issues associated with IV infusion. So the first is that there's no need for the pharmacy to do any of the preparation work. The pharmacy can prepare if needed, but that is not something that's necessary for them to do based on what we've understood in talking to HCPs. Furthermore, this eliminates some of the dosing errors, spills, CSTD compatibility, CSTD cost, these other challenges with infusion we talked about before. Additionally, it reduces some of the other consumables associated with infusion that at least the administration, and the expectation is, if the drug allows, this could take a 30-minute infusion down to something closer to 5 minutes. And obviously, we still have that flushing and post-administration step. This could get the patients out in less than 30 minutes, if possible. And I'm not sure what's going on here, but there we go. So just to kind of to conclude here and to wrap up, this is sort of what we see as the potential future of this infusion device. Obviously, it's still in development, but we're thinking ahead about what this could look like on the market. One of the things that we think it enables, and this goes back to the point about access, is what we call flexible infusion. Essentially, because excuse me, because no pharmacy is needed, this really opens up the possible administration of this device into something like home use with a nurse administering from the patient's home. Furthermore, this is something that we believe other companies and molecules should have access to. We believe it has a greater benefit to society if there are more companies using a device like this, and it improves infusion as a whole. And then finally, there's opportunities potentially to remove the saline. This would have an even greater impact, as you wouldn't have to do the flushing step as well, and it eliminates even further a larger amount of consumables. There's still plenty of work going on to evaluate that, and look for a future presentation on that topic.